Hello, everybody. Thank you so much for coming today. We are going to have a conversation today about prioritization, equity in the global health financing architecture, strengthening systems, and delivering primary health care. I'm Vinita Gupta. I'm a maternal and child health physician and also international human rights lawyer. But above all, I'm a co-conspirator in the fight for health equity. So glad to be here. Very honored to have stellar panel today. A few logistic questions before we get started. We want to hear everybody in the room and also some people joining us online. We want to have interactive conversation. We have plenty of time. We will get the questions from the online audience as well. And also please share it through social media. You might want to use yes health equity as a hashtag. We will retweet your tweets, and then action _ tweets is our organizational handle. This event is being live streamed, and we will live tweet during this whole session. So as I mentioned, some are joined through Zoom here, and then some will have place on the podium. Keynote speaker is Dr. Tom Frieden, President and CEO, Resolve to Save Lives. Priya Basu, Executive Head of Secretariat Financial Intermediary Fund for Pandemic Prevention, Preparedness and Response, World Bank. Asia Russell, Executive Director, Health Gap. Alicia Dunn, President and CEO, Global Health Council. Dr. Joanne Carter, Executive Director, Results Education Fund. And Rosemary Mubaru from Executive Director, Waki Health. So I welcome all of them. I would love to have panelists on the dais, please. So in the end, we'll take a lot of questions from the audience, virtual audience, and as well as in the room. Thank you. So as we know, the last few years have been really difficult with COVID pandemic. It has drastically reshaped health landscape. And it's stressed our existing. The problems were there. We were not having exactly what ideal situation would be, but it also stressed it further. The global health financing architecture, governments, other institutions like WHO, Global Fund, Gavi, SAPI, World Bank, and others stepped up in their own way to respond, to fill up gaps, and to address needs to mitigate future risk. The creation of mechanisms like access to COVID-19 tools accelerator, Act A, and the fifth has added to the health financing landscape. Some challenges, some good things came with them. And And what has also exposed during COVID is the flaws and the inequities that were already existing, but then addition of the challenges increased it further. So what have we learned in these past few years? How do we ensure that we not only are prepared, but actively preventing the next pandemic, those that we are still fighting now, those pandemics? And we are going to get a chance today to discuss this with our speakers. And without further delay, let us hear from Dr. Tom Frieden. And he has been really kind to record the message as he's traveling today at 2:30. So he sent us this message.
Fundamental focus for preparedness has to be at the country and subnational level. It's essential that the intermediary fund learn lessons from other models. How are funds going to enter the country? How are funds going to be used efficiently and targeted well? Through support, Resolve to Save Lives has worked with many countries in Africa, elsewhere on World Bank and other projects. And we've learned 5 essential lessons that I think are going to be critical to success, not only improving our preparedness for outbreaks and epidemics and pandemics, but also for improving health and health systems more broadly. The first is the essential importance of political will, of leadership from the top level of government, of a multi-sectoral response. The second is to have a dedicated team working on preparedness. If preparedness is nobody's baby, it's not going to happen. There need to be people who focus exclusively or almost exclusively on preparedness. Third, we need clear metrics for accountability. Metrics such as 717, that every outbreak is found within 7 days, reported within 1, and all essential control measures in place within 7 days, and the joint external evaluation in its new iteration, assessing health systems. Fourth, implementation of preparedness needs to be tracked in a clear, transparent way. There are so many different activities by so many different actors. Unless there's a transparent dashboard outlining what needs to be done by whom, by when, it tends not to happen. And fifth, there needs to be coordination among partners and stakeholders with the country in the driver's seat, the country determining what needs to happen. International donors, groups, bilaterals, multilaterals need to fit within the country plan. They can suggest changes in that plan, but it's up to the country to determine a plan and follow a plan. Finally, I want to talk about epidemic-ready primary health care, or PHC. Primary health care is essential to improve the health of individuals and populations, but it is the most neglected part of most healthcare systems. Despite the critical importance of PHC, it remains underaddressed and underinvested in. It has been the weak link in many responses to COVID and other health threats. A strong, resilient primary healthcare infrastructure could be a landmark achievement and legacy coming out of COVID. But this was going to require broad structural, financial, and governance reforms so that primary health care systems can both provide ongoing care and detect, respond to, and prevent health emergencies. Epidemic-ready PHC provides diagnosis, treatment, vaccination, and it increases community resilience against health threats. This includes good diagnostics, good therapeutics, point-of-care testing, accurate and timely reporting of various diseases, whether common or rare, improving the skills of providers who have a high index of suspicion for locally relevant epidemic-prone diseases, resilience so that it can continue in an epidemic or a natural disaster. It can be stable in disruption. Healthcare workers who are well-trained and paid regularly with benefits that support their own health and well-being. Let's be frank, all over the world, primary healthcare workers are not adequately paid, sometimes are not paid at all. We give lip service to primary healthcare, but that all too often is lip service only and not real dedication. When you see what's really being paid, then you know what a government really thinks of primary healthcare. It's important also that Primary healthcare workers have defined career paths, ongoing learning, and support from their management and government. And they need to be protected from infections at the workplace, to minimize disease spread, to protect patients and healthcare workers, to maintain trust of the community in primary healthcare. Primary healthcare is a very important way of building trust, because if you're addressing the needs of the community, whether that's for pneumonia or other symptomatic disease, or dental care, or vision care, or dermatological care, these may not be conditions that kill people, but if you can't eat because your teeth hurt all the time, if you're in a great deal of discomfort because of dermatological problems that are readily treated, and if you can't see because you don't have glasses that could be provided for $1 and last a year or 3 or 5, you're not going to trust the primary healthcare system. So we need to think of primary healthcare systems that are trusted by individuals. Epidemic-ready PHC will also have information systems that are accurate, sensitive, easy to use, that improve decision-making by program managers and clinical care by doctors. Simple, measurable, meaningful performance metrics can improve quality. Appropriate information technology can support providers and inform healthcare and public health authorities of suspected outbreaks or diseases. Primary healthcare needs to be able to treat, cure, and stop the spread of all types of diseases, whether sexually transmitted or tuberculosis or typhoid, with a particular focus on equity in reaching vulnerable populations. This includes the capacity to vaccinate a high proportion of the population, including all or nearly all who present to the facility, and all in the community more broadly, who are at risk or otherwise eligible. Primary health care should be the central component of our healthcare system, and with a focus on improving health, such as treating the single leading cause of death in the world, hypertension, which is undertreated, we can see a real impact for these measures, not only in making the world better prepared for the next variant or deadly microbe, but healthier until that occurs. Thanks very much.
So we heard very powerful and clear thoughts from Dr. Frieden, and very good recommendation that we are going to reflect on throughout the session today. And this is going to segue into listening to Priya Bose. And she is around the corner, very close, but soon to leave for the airport. And she has been very generous with her time and with her engaging with the civil society partner that some of you were there yesterday as well. So we welcome her thoughts. Priya, again, thank you so much. Priya Basu.
Thank you so much, Vinita. Can you hear me?
Yes, very good.
Thank you. And hello, everyone. And I'm really sorry I can't be there in person, but as Vinita said, I'm rushing to the airport in a few minutes, and the logistics just didn't make it possible for me to be there. But hello, co-panelists, and great to be with you. We had a very rich civil society dialogue yesterday that Vinita moderated as part of the World Bank IMF annual meetings that are ongoing right now. And I had the opportunity to speak a little bit about the new Financial Intermediary Fund on Pandemic Prevention, Preparedness, and Response. But let me do so again. This fund really is the first ever dedicated financing mechanism to support pandemic prevention, preparedness, and response. There are many institutions, including the World Bank, but also the WHO, of course, UN agencies, global health institutions like Gavi, Global Fund, CEPI, etc., that are engaged in this space. But all of them have multiple mandates that don't focus entirely on pandemic prevention, preparedness, and response. So we see this new Financial Intermediary Fund as a great tool to keep attention focused on this important agenda, even in times when the world is facing multiple crises as we are now. In interpandemic years, we want to make sure that countries and regional institutions do make the necessary investments that are needed to ensure that the world is better prepared when we are hit by the next pandemic. And my friends at the WHO remind me all the time, it's not a question of if, it's a question of when the next pandemic is going to hit us. So we've all learned a lot from the COVID experience, and we're building on those lessons as we design the fund. This has been discussed kind of at length with a wide group of stakeholders over the past 9 months or so. And we had put out a white paper where we got great comments from a very broad range of stakeholders, including civil society partners. We've done our best to accommodate those comments. Some of the founding principles of the fund are equity and inclusivity. So that has been sort of built into the governance structure. We've been working very closely with the founding partners. We now have 22 donors to the fund that have contributed $1.4 billion US dollars. We've been working with them, but also with co-investor countries, as we call them, which are the countries that would receive financing from the fund. We have a board structure which is again very equitable. We have 9 voting seats for constituency-based seats for the sovereign contributors. We have 1 voting seat for foundations, philanthropies who are also contributors. We have 9 voting seats for sovereign co-investors who are sort of, again, constituency-based seats for the countries that could potentially benefit from the fund. We have 2 voting seats for civil society organizations. And then, of course, we have a number of observers on the fund's board. It met for the first time on September 8th and 9th, when it approved its governing documents and elected its co-chairs. And the co-chairs are Dr. Daniel Ngamije, who is the health minister of Rwanda, and Dr. Chatib Basri, who is the former finance minister of Indonesia. The secretariat is hosted by the World Bank. I'm the executive head of the secretariat, and we have in the secretariat also provisions for secondees from the World Health Organization. And then the board met again for the second time last week on October 7th. We're moving forward very expeditiously, but at the same time, making sure that we get things right. There's a balance there that needs to be struck. And at the last board meeting, the terms of reference of the technical advisory panel, which will be a key body in the fifth, which will be advising the board on what kinds of funding proposals to support. It'll be doing the evaluation, the technical evaluation of those proposals. The terms of reference of that panel were approved, and we're now moving forward with constituting that panel. We'll be putting out a call for applications to serve on the panel very shortly. Those will be announced both on the fifth public website as well as the WHO's website. So, and then we have, we're working on designing what the funding allocation principles should be, what the first call for proposals should focus on, what the priorities of the fifth initially, but then over its 8-year lifetime should be. So all of that work is ongoing, and our civil society board members, of course, are part of that discussion, and we also hope to be able to capture the broader voices through them of civil society into this discussion, because as we all know, civil society isn't homogenous. It's not even homogenous within an individual country, let alone globally. So, we are keen to incorporate the voices of CSOs into what we do. Just in terms of kind of some of the points that Dr. Frieden mentioned earlier as well, measuring success, metrics are very important. So we are placing a lot of focus on getting a good results framework ready, which will help us then define what results we want to achieve over the 8-year lifetime of the fifth, but also what results we want to achieve, in the initial phase through the first call for proposals. And those results obviously have to be tied to very clear metrics. At a very broad level, in terms of impact, we are looking at the 717 metric that Dr. Frieden mentioned in his remarks, which is a good way to measure the capacity of countries to be able to detect detect, report, and respond to new emerging pandemics. We also have the 100-day mission, which could serve as a complementary metric. And then, in terms of sort of individual outputs, we're looking very closely at the WHO's SPAR and JEE metrics, which kind of help you measure capacity along core dimensions of PPR, things like, building country-level surveillance capacity, building lab capacity, health workforce capacity, including community health workers, infection prevention and control in medical facilities, zoonotic diseases, how to make sure that the One Health approach is sort of captured in everything that we do, given that so many of the recent pandemics that we've lived through have zoonotic origins. How can we, invest in medical countermeasures to make sure that there is equitable, affordable, and early access to these kinds of medical countermeasures when the next pandemic hits us? I think that's a big lesson we've learned from COVID. So these are all kind of some of the priorities that we're looking at. But there are some things that really cut across health workforce, including community health workers. That really cuts across all the various kind of core capacities that we want to build. So, we're focusing on that. Country is the lens through which we're looking at things, because, all these capacities, you have to start at the country level, and then you can aggregate them up to the regional level and sometimes the global level. But, we are, the first call for proposals will seek proposals that are, country-based solutions. And then, also, some regional-based solutions. I think we saw from the recent pandemic, the Africa CDC, for example, did a stellar job, and the World Bank has been involved in working with the Africa CDC over the years. But things we can do to strengthen their capacity and also the capacity of other sort of regional organizations or create new ones. This FIF is a financial intermediary fund, so it's working through intermediaries. It's not supposed to, crowd the global health architecture with yet another new kind of entity. It has a very light structure, and it will work through existing institutions that are involved in PPR. So the way we will work is to complement the financing, channel the financing through UN agencies, through MDBs, through global health institutions. Right now, we have 13 initial implementing entities, but that group will likely be expanded over time. The board is looking at ways to make that group broader. But those entities are expected to sort of work closely with countries and prepare proposals jointly to ensure that there's coordination on the ground around the national priorities of countries. So, one way of approaching this is that countries have their national action plans for health security. Some pieces of those plans are funded, some pieces are not funded. So, countries will identify where they need assistance, and then the implementing entities will work together in a coordinated manner with countries, prepare proposals, submit those proposals. The proposals will be reviewed by the technical advisory panel that the WHO would be chairing. That technical advisory panel gives its recommendations to the FIF's board. The FIF's board has, its own higher level set of funding principles. And then, ultimately the money will be allocated. And right now, in terms of the time frame, so we hope to be able to issue the first call for proposals later in this calendar year or very early in the next calendar year. And then, the countries and implementing entities will be given a few months to prepare the proposals. So then, they'll submit them, and then say around, spring or a bit later, 2023, those proposals will be evaluated. So we expect that the first round of funding would be allocated around the middle of next year. So that's kind of the time frame. And just kind of to say that this is one part of the solution. There's a lot of investment needed in strengthening the pandemic prevention, preparedness, and response capacity of low and middle income countries, which is the focus of our fund. And we realize that right now, we have $1.4 billion, but the needs are, far greater. So that is why, we're focusing very much on kind of the, making sure that the grant financing from this fifth would be complemented by the financing of the implementing entities themselves, and then also to look at ways in which countries themselves can contribute and sort of sustain these efforts. So every dollar of grant funding will hopefully leverage a few more dollars of money from the implementing entities, and where possible from governments themselves. Of course, we recognize that some governments are very fiscally stretched in low-income countries, but when it comes to middle-income countries, those governments should be able to put in their own resources that would bring additional funding. So additionality, complementarity, coordination, incentivizing more investments in PPR. These are some of the key words that key principles that we are very committed to, and working together with others to make sure that these efforts are sustained over time, so that the world is better prepared for the next pandemic, and particularly low income and middle income countries are better prepared for the next pandemic, and have the necessary capacity in place, have the tools in place to be able to mount effective responses. Every dollar that we invest now in pandemic prevention, preparedness, and response, we know will not only save lives, but also save resources in the future. So, it really is, it is a kind of investment that yields very high social returns, saves lives, and saves economic costs for the future. So very much looking forward to continuing to engage with you and hearing from you. We're still in startup phase, so over time we will be putting out a lot more information on our public website, and communicating in real time and getting your feedback. So thank you again for this opportunity.
Thank you so much. If you have a couple of minutes, I have a follow-up question for you.
Sure.
You mentioned that how FIF is going to be part of this global financial architecture and not create another crowded new entity into it. Could you share your thoughts on how FIF plans to or have learned from the existing mechanisms who have been around for many decades, and they have progressed, or somewhere they worked, somewhere they didn't work? So any thoughts on how you are thinking of drawing upon their experiences, successes, as well as challenges?
Yes, so that's a great question. So in a way, since these existing institutions are part of the partnership, they will each bring their own lessons as well in designing proposals. So, we're encouraging them all to sort of reflect. We've been doing a lot of reflection ourselves as well. So that will feed into the proposals, but, that the FIF receives, the project proposals that the FIF receives. But, at a higher level, I think one thing that we've learned is that there are, there's really need for better coordination, amongst the existing institutions, and that's sort of something at the country level. There are cases where, a variety of institutions are working with a country partner, but there are overlapping mandates. So, this is something that we really want to address to the FIF. We are actively encouraging, if a proposal is going to come for Liberia, or, just take that as an example, we want to make sure that all the actors, international and local and regional, that are engaged in, helping Liberia strengthen its pandemic prevention, preparedness, and response, that have come together and make a joint proposal that will really reduce the transactions costs for Liberia and improve outcomes. So that's kind of one lesson on coordination that we're very sort of committed to. And then in terms of kind of individual sort of learnings for each institution, I think each institution has learned something different, but For us, we of course are very committed to, in the design of our projects, for example, looking at things through a gender lens. Now every project that we prepare has a gender sort of risk assessment in it. We've learned from the pandemic that there are things that can be done differently to protect women, and to bake that upstream into the design of projects. So kind of that's one concrete lesson. And of course, results and accountability, we're very committed to that. Transparency. I don't know if that addresses your question, but there's a lot of reflection going on, and that will be captured in the proposals, the project proposals that are prepared. And that the fifth, of course, I sit in the secretariat, so I don't prepare the proposals, but, the call for proposals, when we issue them, we will be putting up, we will be making it clear what is it that we're looking for, in terms of the kinds of proposals. I mean, another big lesson is the role of frontline workers and community health workers, and, how they need to be, their capacity needs to be strengthened, and they need to be supported. So that's kind of going to feed into the priorities of the fifth. Thanks.
Thank you so much, Priya, and have safe flights. Thank you so much.
Thank you. And I'll catch up with you to get feedback on the discussions.
Absolutely. We'll share the notes as well.
Thank you.
Now we turn to our panelists in the room. So to hear from them, what can we do in this complex situation we are in, which is further complicated by new mechanisms, new challenges with the COVID? How do we strengthen our health systems and deliver on PHC? So I want to start from that side. Alicia, from you.
Thank you, Vinita. Thanks to Action for having me. As Vinita said, I'm Elisha Dungiorgio. I'm the president and CEO of Global Health Council. Hi to everybody in the room and online. For those of you who don't know, just a little background, Global Health Council is a DC-based membership organization. We have over 100 organizational members that span the range from academic institutions to INGOs, CSOs, and private sector. And we all work together to improve policies and resources for global health, both bilaterally and multilaterally. In addition to that, I'm also one of the civil society representatives that Priya just mentioned, with a seat on the governing board of the new financial intermediary fund, which has quickly become like a full-time job. So I'm happy to talk about that as well. I think Dr. Friden's comments were right on point, and I heard him say many times, either use the word local or communities, and I think that's been a real challenge to get that up to scale. I mean, it's not a new conversation to talk about fixing the global health architecture and global health financing. I mean, I think most of the people in this room have been having those conversations long before COVID showed up. Whether it was about harmonizing financing, vertical silos, too complex supply chains, colonialist practices, I can go on with this list. I think what COVID did, though, is kind of give a wake-up call to high-income countries that poor global health architecture is also a problem for us. And all of a sudden, there is now a sense of urgency to create new mechanisms, to develop new financing funds, to think about how to engage communities, but whether we're doing that in the way that really is needed, I think remains to be seen. And, for me, just reflecting on this, I think we have kind of a central tension here, is that we talk quite a bit about fixing the global health architecture, right? And that means we focus on the global and we focus on the architecture, which talks about the donors and the financing streams and this kind of big web of players. But the health piece doesn't get talked about as much, and the health delivery, services, design is inherently local. And so right now, I think we still are in this position where we have global architecture as the starring player and local health as a supporting piece. And we need to shift that paradigm and flip that. Local systems, local communities, local health service delivery design, that should be out front, and the global health architecture should support that. I think you heard that from Dr. Frieden, and I think that the intention of the fifth is to, as Priya said, have that country piece up front, but I think country ownership, as we know, is different than country co-design. And so that remains to be seen if that is the question will be answered. I think I was supposed to talk about Act A as well, which Vinita mentioned in the beginning as being, you know, a new thing created, as we know, during the pandemic to solve some of the issues that we have with the global architecture. And some of you may have seen an external evaluation of Act A was just released earlier this week. And there were some really positive things there. I mean, it was and is still, because it hasn't sunsetted quite yet, and it remains to be seen if it will be sunsetted. For the architecture that it had to build on, it was a pretty innovative idea in the moment, right? And I mean, we weren't prepared. None of us were prepared for the global airborne pandemic of COVID. And so starting that up met some of the needs that probably would not have been met if we didn't have Act A. I think in that evaluation, there's a lot of really good lessons learned about, you know, the pillars that were more successful in Act A are the ones where there were established working relationships between the entities responsible for those pillars. So they had already been communicating before the emergency situation. They had built networks that were complementary. The pillars that were not as successful were the ones where they had to build everything from scratch. And so one of the real takeaways from Act A is that building relationships between local and global and with communities should be a constant piece of work for us, all of us in global health. It's not something you can start up in the middle of the emergency and be successful. There is a summary in that very long evaluation document with a kind of cheat sheet of what's in there. So I encourage everyone to take a look at that. I think with the fifth, you know, I mean, Priya gave a kind of long, detailed piece about that. So I'll just focus on the civil society piece. So it is a big deal to have, from the inception of a multilateral fund, civil society to have voting seats, right? Not be observers, but we actually get to vote. Priya said in her remarks that some of the underpinning thinking with that is that the governing board needs to be equitable. I want to just challenge that a little bit. I think we took steps to that. But again, I'll say, you heard her say there's 9 donor country seats, 9 co-investor country seats, 1 philanthropy seat, and 2 civil society voting seats, and we have 2 alternates. My role as the primary representative for the Global North is to represent the Northern Hemisphere of civil society who has any interest in any of the areas that pandemic preparedness and response can cover. So you heard Priya mention health systems, health workers, surveillance, One Health, you know, zoonotic spillover, like that's a big range. And my counterpart, Jackie Chiari from AMREF, who is the primary representative for the Global South, if we're just going by population size, she has an even bigger contingent to represent. We don't have resources. I'm not getting paid to do this, right? I mean, we're not set up for this as civil society. So all of our efforts on this are volunteer, and we think it's important, and that's why we're there. But we don't have the mechanics that a country government has, or even a philanthropy, to engage in the same way. And I'm not suggesting that we need equal seats, because our roles aren't equal. We need equitable seats. And so we're taking steps there, but we're not quite there yet.
One thing I can say, I don't envy you.
We appreciate it a lot.
It is a difficult space to navigate, representing the civil society, which is not homogeneous, and then being on the seat and see kind of negotiate how much you can get on behalf of the civil society. So thank you for doing that. So next we will go to Joanne, if you can share your thoughts.
Sure. And for those online, great to be with you and see the folks in the room. I'm Joanne Carter. I'm the executive director of the grassroots advocacy organization Results, and also one of the founding members of the Action Partnership. So I might start with, Vinita, what you started with right at the very beginning, which is just, again, acknowledging what all the folks in this room know, which is the sort of massive and lingering secondary impacts of COVID, you know, whether that is the prolonged reductions in basic immunization that really have not bounced back, whether it's the gaps in reduced access in women and adolescent girls, access to health, to reproductive health, whether it's TB treatment, which took a huge nosedive after really, some real progress and again, is only very slowly recovering. And we all know that starts with like translating into increased illness and impoverishment. And again, with global health equity set back. And I raised it in part because one of the lessons we learned from COVID is that the impacts of the pandemic were not siloed to just a new virus, and our approach to stopping it cannot be siloed. So, for me, like there's so much conversation now about pandemic preparedness and response, including financing, but I feel still with a focus that threatens to be siloed and narrowly defined, and, in some ways defined by high income countries. And so, again, going back to what, Alicia, what you said, what Tom Frieden said, as we look to what it takes to ensure more equitable and effective pandemic preparedness and response, it's the same thing that we need to drive more equitable healthcare overall, which is a primary health system that reaches everybody. And again, to that point, that pays community health workers and treats them well. And this has got to be a top priority for health investment because it's how we're going to get all this stuff. And we've seen it with COVID, it's worked better, not without damage to some of those other systems, but it's worked better when they've been able to build off existing systems. Like I know, because I do a lot of work on TB, that particularly in Asia, a lot of the response was built on TB programs, but those programs were already under-resourced, right? And so resources went from TB to COVID rather than, really having the kind of strong system that could take care of existing and new pandemics. And it feels like we're considering theoretical new mechanisms while failing to finance the response to Ebola in Uganda right now. And so for me, it's like, how do we bring this together? And we cannot replicate harmful old models, where the focus is dictated by the donors or by high income countries. And I think we need to focus, for me, on health financing systems and mechanisms that have a proven track record, but in a few really key areas, right? One is effective delivery that tackles critical epidemics now and helps build out those primary health systems, and really rejects the false choice between like pandemics now and pandemics in the future, so that can be saving lives now and building that capacity. And also like equitable delivery that reaches the most marginalized groups, whether that is key populations, criminalized populations, impoverished communities, and also that really mechanisms that center community-informed and community-led responses, community system strengthening, community-led monitoring, because that is going to get us the best outcomes. And I would just say candidly, I don't feel like the fifth has proved that yet. It is not it's not impossible. It's not too late, but unless and until it can, I don't think it should be getting more resources or more political support. So I think it needs to prove that effectiveness and then see how it then fits into that delivery system. And I would say again, as you heard, like effective and equitable governance, really critical. It's critical not just sort of in a theoretical sense, but because that's how you get better decisions. And I really appreciated the nuance of what you described, Alicia. So, after a really rough start, it feels like the fifth has taken some of those steps, it's done some of it, but more to be done for sure. And we need to support our colleagues that are leading that on the fifth. But right now, the fifth board is also facing absolutely central questions of how and where to invest. And so, it's got three proposed focus areas. You can say more as well, but country capacity and health systems, regional and global capacity, and technical assistance. And it feels like that country capacity and health systems, really those community-led systems, has got to be the overwhelming focus. And I would argue it has to be done through reliable and multi-year funding, which is what allows countries, and civil society and partners to plan and do that work in the right way. So, and I'm just, again, concerned that many of the sort of fifth's implementing entities are not set up to do that. And so we really, again, need to make sure that resources for pandemic preparedness that feel really precious right now flow through the right entities that, again, effective delivery that tackles current and new pandemics, equitable delivery, centering on community informed and community-led processes. And just so to end, for me, that points very much to the Global Fund and other entities as well. I mean, I see work that Gavi's done a little bit more narrowly, but really importantly, but for me, it points to the Global Fund. It is a tool that the global community has invested in and built over 2 decades. While it's not perfect, those of us that work with it know that it is one of the most effective ways we have to actually get resources to community-led health with locally driven human rights, but also, lots of evidence of impact and proven outcomes, and funding civil society alongside of governments. And, the world just last month mobilized a record 14.25 billion for the Global Fund, but we really need to, finish the job of getting to that 18 billion. There's more pledges coming in, but that will be absolutely critical, both to tackling AIDS, TB, malaria, but also building those healthcare systems and building the capacity for pandemic preparedness. So no question, we need more resources for pandemic preparedness and for primary healthcare. But for me, the question is not whether, but how we do it. Because if we do it right, we move all these things forward. If we do it wrong, we fail across the board. And, the consequences, again, they don't fall to us. They fall to the people that are already the sort of most marginalized and most vulnerable. And so we just have to get this right. So thanks.
Thank you, Joanne. And so right that it's a false choice between responding to the existing pandemics and preparing for the next big pandemic. It's the same solutions that we have. And as Joanne mentioned, she's also chair of the Action Partnership. And you guys might be envious of us because we at Action Team get to hear her wisdom and experience very often. So thank you, Joanne. Now we'll go to Rosemary. Rosemary is, Sabina, do we have her connected? Thank you, Rosemary. And she is zooming in from Kenya. Is that right?
Right.
Thanks for being up so late. Thank you. Please go ahead.
You're right. So thank you very much. I can't see who is in the room, but I can see Asia, I can see Joanne, I can see Elijah. So very happy to see you all. And I know there are many colleagues in the room that we have worked with. So very happy to come to you from Nairobi, Kenya. And as I sit here in an implementing country, all the things that my co-panelists have mentioned are really alive here and really resonate with what our day-to-day experience is. And as we discuss and think, reflect, and plan about future pandemics, it is very difficult to sit here and just know that just next door in Uganda, we cannot talk about future pandemics because it is now, it is happening now. With about 7 confirmed cases, about 1 confirmed death, that is what we are living right now. And in the region, there is that fear. But also, at a global scale, we do not that even Ebola could mutate to more easily spread between people, and therefore a really huge threat, of a pandemic. And therefore, I think the things we are discussing now and the plans we are having for the future, it's very important to just think about even now, like what's happening in implementing countries. And how do we ensure that we do not see more implementing countries? I mean, Ebola has only largely affected African countries, but, we are hardly recovered from COVID. And the far-reaching implications and impact of COVID are still being felt very, very much. All of us, we know that a lot of our governments in implementing countries were responding to COVID-19 by borrowing. And therefore, the debt crisis is real in most of our countries. So when we talk about strengthening health systems, when we talk about additional healthcare workers, community health workers, and all the beautiful things that we would like to see when it comes to strengthening health systems, the biggest question is, how are implementing countries supposed to do that? While still surfacing like really huge debts, while still recovering, while still losing healthcare workers. In Uganda, the confirmed death is, I believe, is that of a healthcare worker, and many more at risk. One of the things we saw during the COVID pandemic is, the fact that in many of the conversations, at a global level, even with the ACT-A mechanism, implementing governments were not necessarily on the table. The intention was there, but we did not see many low-income countries and lower and middle-income countries actually participating in the conversations. And what we then saw later, with the scarcity of vaccines, with the scarcity of therapeutics, and having implementing countries or countries in, with high burden or low and middle income countries being the last in the queue to access the technologies. What we saw is that even when we finally were able to access vaccines through the dose sharing, and even when our governments procured those through COVAX, we still saw a really huge challenge of delivery. We still saw that it was difficult to translate the vaccines into vaccinations, or what we also called from the tarmac to the arm, a shot in the arm. And so I think in terms of reflecting to my question and the topic of today, in terms of the role and the importance of law, of implementing countries, I think it's really important that implementing countries are on the table when the conversations are happening. We need to hear at the design stage. We need to hear when we are planning, from the onset, how are implementing countries planning to deliver, whether it's the technologies, how are we planning to deliver the programs? What are the challenges that we can foresee and be able to preempt them, be able to work on them way ahead? We saw a really huge hype, on media saying that implementing countries were talking about scarcity of vaccines. And then when we got vaccines, we could not absorb the vaccines, which was not true. The vaccines arrived with only like a month shelf life. And so, but also because most of the implementing countries are not designed, for pandemic, delivery of pandemic tools and technologies. We do a lot of routine immunization, but when we fail to link those and to integrate those programs, then we miss out on the opportunity to leverage previous investments. We lose out on the opportunity to ensure that we can have very strong programs that can deliver, and the issues of absorptions should not be issues or challenges that we face any longer, given that we have had many lessons to learn, right from the HIV epidemic to so many, and now we had COVID, and the things we learned about 30, 40 years ago with HIV response, we found that we actually learned nothing, because we went back to the same problems when COVID came. And so as we think about future pandemics, I think it's very important that processes are co-created with implementing governments. It is important that we are thinking about implementation, we are thinking about delivery, we are thinking about absorption, even way ahead of time. I think the other important role is about country-led prioritization and agenda setting. Having countries really determine where the investment should go, determine who are their missed populations, or which populations in their countries are most likely to be missed by health systems. But, I think that is the ideal. In the current global health architecture, we have a lot of agenda setting that is not necessarily set by the countries. Mm-hmm. There's a lot of agenda setting that is influenced by where the resources are. A lot of agenda setting influenced by many other power dynamics. And I think that's something that we need to work on if we are actually going to realize the equity that we talk about, the equity that we are pursuing. So those are some of the reflections I wanted to bring, but I also wanted to touch a bit on the fifth, because like Priya said, we're going to be seeing the RFPs coming out, countries will be submitting proposals, but the biggest question perhaps one would have is, the implementing countries that are going to be submitting proposals, are they at the table right now, listening to the discussions? Are they aware of where this is coming from, where it's going, and even the nature of what we are dealing with right now here. One of the things we learned with COVID-19 is that even with the investments that became available, through the bank or other bilateral engagements, most implementing countries, when we reached out to them, they said they do not know where to begin the conversation. They did not know how to engage. And so the resources could be there. There's a lot of goodwill, but I think if we do not start right now in terms of engaging and preparing, we might once again be saying we need to learn. And I think there has been a lot of lessons that we need to leverage. When it comes to, I think, implementing countries, it's important to also, I think, tying that to the community element in terms of community engagement, community participation. It's very important that we reflect and we think about the value of social participation. Because with social participation, you really get to hear the kind of investments, the kind of programs that the people want. So basically, across the board, all the stakeholders, what do people in Kenya really want, for example? And unless we are investing in social participation, unless we are putting that at the center of everything we are doing, unless we are putting communities at the center of everything we are doing, we are going to miss out on that voice. And then we will be leaving some people behind. We will not be working efficiently. Because I think if we are talking about making things work better by being more efficient in how resources are utilized, in how resources are allocated, you cannot have that conversation in the absence of implementing countries, because who is going to implement? Really, who is going to be the fund manager for these investments? It is the country level. It are the governments of the countries that are going to access the funding. We also cannot have that conversation in the absence of stakeholders such as communities. Because I think we all value the accountability element that communities bring, whether it is through community-led monitoring, whether it is, the real-time monitoring, because investors, partners, civil society, we all value the accountability because it helps us to make sure that there is value for the investment. It makes sure that we get the results that we want. But unless we have communities designed into the program right from the onset, unless we have that accountability role of communities and civil society, I think going back to Elisha's point to say that it has to be intentional in terms of including these elements and components into the design stage. So I think, Benita, I would just make those quick remarks, in terms of the role of implementing countries, how it links with communities, and really to say that for the equity that we are all fighting for, we have to do something different. And I think the global health architecture needs to rethink how we are structured and how the roles, of implementing countries and investors can actually be arranged in a much more reinforcing way, a way that helps to co-create processes. Thank you. Over to you, Benita.
Thank you so much, Rosemary. It's almost like Global South having seat on the table. If it wasn't so problematic, it would be comical how it has become symbolic and really far from where we need to be. Like Rosemary said, it's right from the beginning, the thinking, co-creating rather than just having at the time of implementation. It's just, it's the rhetoric is like so good the way it is written that, and then it keeps on, you can copy and paste from one to another and will look great, but far from a place where they're really empowered seat on the table, who, when, where. Some of the mechanisms that are existing have done a better job than others, but I think we have scope for improvement in each of those mechanisms. Asia, now we turn to you for your thoughts.
Thanks. So my name is Asia Russell, and I'm the executive director of Health Gap. And Health Gap is an AIDS advocacy organization working in the US and globally to hasten an end to the AIDS pandemic by working for health justice. So the dimension I come to this, come with to this conversation is one of aid speed, the speed of accountability, not just as a buzzword, but as a matter of life and death, which I think is commonplace to anyone who's recognizing how much in common the AIDS crisis and its response has to these fundamental issues of primary healthcare service delivery and access. I think outside of this room, many people talk about them as at odds with each other, as if somehow the woman living with HIV who needs a safe delivery or a safe abortion is different from the person who needs good glasses and good dental care, as Dr. Frieden was mentioning. No, they are the same communities. And it's us who understands that with the most urgency. And that's the reality, not just the legacy, but the reality here and now of AIDS activism. Because let's face it, the pandemics of HIV, TB, malaria, preventable maternal mortality, these are the pandemics of here and now that have to be defeated as we simultaneously embark upon preparing for and responding to the pandemics that are crushing us right now. So I guess I feel extremely cynical about the fifth. I want to be honest, because what I see happening, as Rosemary really pointed out, is the deployment of a lot of these ideas and themes, unfortunately, I think as buzzwords rather than as something that are things that are deeply and genuinely felt. And I'm not ascribing any bad intention to any duty bearer. I'm just looking at the facts. So we are not recovered from a 2-year mass death and mass disabling event, which profoundly exposed and exacerbated inequities in primary, secondary, and tertiary measures. So let's look at the outbreak of Ebola in Uganda right now that Rosemary was mentioning. So we have 54 cases confirmed, 19 cases dead, confirmed, only that we know, 20 cases, mainly of health workers, recovered, which is incredible when there's no vaccine. Every Herculean force against health workers leveraged on them, getting paid the worst salary in the region. In an authoritarian state, we're talking openly about remuneration, about access to PPE, is actually something that triggers intense surveillance by government. And that's just a reality, because these are issues not just devoid of politics, but are actually intimately interlinked with politics, because that's the nature of health, and that's the nature of health inequities. So I want to talk about the death that just happened October 7th in Chirudu Hospital, which is a crowded hospital in Kampala. A person traveled from Mubende because he was desperate to get health services that he couldn't receive in Mubende, which is where the outbreak was detected originally, right? And where a regional referral facility in Fort Portal was mobilized to try to respond, again, heroically to the cases coming in. This person was terrified of that's what we assume of the services he needed not being delivered to him in Mubende. So he went where everyone goes, which is to Kampala. Importantly, he didn't go to Mulago, the quaternary care facility that recently was radically privatized, and all maternal healthcare services were devolved from Mulago, because Mulago has now become a super specialized VIP facility where you have to pay literally hundreds of dollars to get quality maternal health care services. Everyone is offloaded to where? Chirudu, where this gentleman went. I bring up Chirudu because 2 years ago, a hero in the fight for maternal mortality and access to safe abortion services, Charles Chigundu, died of COVID in that same facility. He had been a champion of maternal health care services for his entire life. And he, delivered babies to so many ministers and so many members of parliament in Kampala, you can't even count them anymore. He collapsed at the bedside of a young woman delivering a baby with a pulse ox of 30. He couldn't even get a bed at Mulago, the place where he had saved countless lives. That's the nature of pandemic preparedness at the site of pandemic response that is teaching the world how to do it right, and that's Uganda. So that dichotomy, but visited in the death of Dr. Charles, who many in this room probably know. If not, please read his obituary in the Lancet. You'll learn more about him. And that's the same place 2 years later where this gentleman has died. Now, the story doesn't end there, because his wife is in a health center for Chitebi, just a few miles away. She has, as Ebola now, she just successfully delivered a baby who's alive, and she herself is still alive, and health workers are scurrying to give her the services she needs. Again, without support, without solidarity, without PPE, without remuneration, without the backing of this supposedly solidarity infused global community. And we're going to learn lessons from Ugandans about what to do wrong, not because they're doing it wrong, but because the duty bearers are, and what to do right because they're doing it right. Finally, about 300 doses of a vaccine is going to be delivered experimentally, which is extremely important. But already health workers, including the 20 who were recovered, have said, we need the frontline protection. And they're bravely speaking out because, again, let's remember politics. It's hard for them to open their mouths and know that they will continue to get a paycheck, continue to be safe, that their family will continue to get the services that they need. So let's think about those two nodes 2 years apart and understand whether the world is or is not serious about pandemic prevention, preparedness, and response. It could be the 15 million deaths that occurred, that devastate us all from COVID, the excess mortality plus the directly counted 6 million deaths. They're devastating. They keep us up at night. They're in particular devastating because they were preventable. And so much of the loss and the despair was because of the fact that pandemic response didn't include continuity of primary healthcare services or responding to health rights violations like LGBTQ members who were arrested, detained, assaulted in East Africa as part of a public health response, which was completely illegitimate. So we know that those things happen. I think the question for the fifth is the measure of its legitimacy will be in whether or not it sweeps these things under the rug or whether it bakes them into its own infrastructure. And I would argue it has to be the latter, and it can be the latter because we have PEPFAR, we have the Global Fund, we have institutions that were forced, frankly, kicking and screaming in some cases, but have now shown up. And of course, some of it is still tokenistic, but there's more than just lip service paid to measures of accountability, to translating seats at the table to meaningful impact. And I'll give one example and then wind down. And that's this issue that Rosemary mentioned about inclusivity. So the question for the fifth is, who's going to get to actually design the request, right? And to say nothing of who's going to receive the money. Because if you ask the health worker in Chirudu, who now has to go back to her community and be accepted again versus be spurned out of a concern that they might spread Ebola, then perhaps the priority would be in remuneration, PPE, plus community education that is led by communities about safe reentry and how to trust the health system and why one should do that. All these things that's not bright, shiny new equipment, Joanne, as you were saying, that would just like sit unused in a closet, but is the opposite, is the nuts and bolts of pandemic response and preparedness, which are people, the same people who deliver primary healthcare services. And that's not what the US government is meaning to prioritize necessarily, or the World Bank when they sit at the table of the fifth. So they have to hear directly from communities about why that kind of intervention needs to be first in the queue, and those kinds of people need to be first in the queue to request the resource and to receive the resources. And the existing structure is absolutely not set up to do those things. So I guess that's the final point, is we have between now and the call for proposals to insist that the fifth, and I know Elisha will be at the leading edge of doing this, seriously, to insist that the fifth walk the talk, or else there is no need for it to exist, because we don't need another distraction on the road to pandemic prevention, preparedness, and response that is led by low and middle income countries and their communities who know the most and who have the most to lose or to gain. If the fifth can't deliver, it must shut up and instead center those communities and give the resources, directly to them. And obviously multilateral development banks are absolutely poorly equipped to do that. It does absolutely the opposite. If you just look at the track record of the World Bank, it has a long history of actually doing harm to health systems rather than delivering impact and delivering accountability. So I think we all have to be honest about strengths and weaknesses of the architecture arrayed around the table, and then listen to the individuals, the communities, the networks, and the governments who have the most expertise and the most skills, and who need this 1.4 billion down payment to deliver now so that it matters whether or not billions more are raised later.
Thank you, Asia, for such powerful words. And then I think that many of us share your cynicism, who have been working more than quarter century on one issue or the other. And me personally working when I was living in India and then seeing that side and then now seeing here. And if I go back, recall, Asia, we were 20 years ago on the another side of the one side or the other of health equity, whether it's access to medicine or treatment for HIV or how medicine get to Africa and how the pharma exerts pressure to curtail that. And we just get up and keep fighting. Despite that cynicism, we get over it and then keep fighting. So I really want to appreciate your such a long-standing, and I feel honored to have worked with you on different campaigns. So after this, I think that we're going to go into some of the questions. So a little bit deeper, dig deeper into some of them. We discussed overall big picture and dived a little bit deeper. So fifth, how do you think, and I'm going to go one by one to all panelists, how do we think that fifth might impact the PHC? So their existing mechanisms are already working on the PHC. How this addition of fifth might impact either way, good or challenging way. Any thoughts on that, Alicia? Since you're over there, we'll start with you.
So I think the hope is that the impact is positive, but I mean, Asia knows that I'm pretty cynical. I'm trying to keep it together for the panel. I think that we have a couple of issues here, right? So it seems now the fifth is in early days. I think this is the first thing that we have to keep in mind. We've had 2 board meetings, and the first one was just to set it up. I mean, that was essentially kind of the World Bank protocol about what papers you need to have in place to have a fifth and working out some of the details of that. The second board meeting was a little bit more substantive, but when you have 150 representative support staff, observers on a Zoom call, you can imagine that it can be kind of hard to get through an agenda in 4 hours. That is the start of how do you spend $1.5 billion. So now we're moving into a phase where the parameters of the technical aspect of the call for proposals, the kind of priority areas will be decided. The results framework will be decided. Priya said some of this in her remarks, and the funding modality and how implementing entities, that list of 13 kind of pre-approved MDBs, Global Fund, Gavi, CEPI, and some UN agencies, how they are expected to interact with country governments and beneficiary communities. None of that has been decided yet. It's all happening in the next few weeks. The call for proposals was initially desired to be announced November 15th. That's not happening now. And I will say there's outside political pressure that's influencing some of this timeline, right? I mean, Indonesia is the co-chair of this governing board along with Rwanda. Indonesia is chairing the G20. The G20 is in November. There's other things that stack up here that aren't just about the pandemic response and preparedness needs. I think, though, everyone hopefully has realized that's completely not feasible. And so now we're looking at December 15th, also does not seem feasible to me. And many of the co-investor countries, there's 9 of them, who I can't remember all of them right off the top of my head, so apologies on that, but raised a very important issue that December 15th is the start of a season when many countries go into holiday mode. And so to launch that and ask people to work through a holiday season and gear up is not going to engender any goodwill for the fund. So there's also a proposal to push it to January 15th, which I don't think was the desire of the governing board overall, although civil society certainly was pushing it. But I think that in practicality is what's going to happen. So looking at the priority areas, there's a long wish list. I think we're so far focusing mostly on a couple of things. At least there's been, statements of support for a few really rose to the top and were repeated. So one was surveillance and cross-border and regional coordination. One is investment in health worker training and health systems capacity. And then I think there's some other ones that follow onto that with, One Health agenda and the like. What those look like, though, in practicality, I don't know. And part of getting the technical advisory panel put into place is to help flesh that piece out. So I don't have an answer for you. I hope it's a good impact, but I'm going in it skeptically. And as I just said, we've really been pushing this idea and concept in practicality in the language of these documents that were being shared, that we have one diverse representation on this technical advisory panel. It's not just about having epidemiologists on there or pathologists, but that we need to really have people with experience in community capacity outreach and building and frontline healthcare, and civil society advocacy and the like. And then, wherever we've been able to insert language about the governing board and the secretariat being accountable and transparent about decisions that have been made, we've been putting that in as well. And much of it has been accepted, some not, but we continue to push.
Thank you. Thank you. Can we go to Rosemary? Rosemary, your reflections on how it might affect PHC?
Right. I want to begin by saying that there's definitely a need to reclaim health as a public good. In many of our areas in our countries, there is a significant level of mistrust of the health system. But I do think that primary health care, when done well, offers an opportunity for us to reclaim health as a public good. And I think we can generate, develop, and build trust using PHC as an entry point. One of the things we saw with COVID, I think important to mention, especially from a community health workers' point of view, we have said a lot of good things. They were definitely the guardians of our continent, for example. And one of the, I think, striking things is that we saw a lot of cases of gender-based violence during the COVID. But it's interesting because the community health workers were the safety net, were the places that most of the survivors of GBV could actually access and talk to. And that level of trust is something that is very unique with community health workers, community systems, and public primary health care has that opportunity to leverage that, especially when the primary health care system is very well constructed to include community health workers, community systems within that, as part of the whole, basically. I don't think they should be too separate. I think community health systems really are an integral piece and I think a core of health systems, and therefore primary healthcare offers a really good opportunity. I think with Asia gave us a really good case study that speaks to all the points that really give evidence and inspiration and motivation of why we should continue to invest in communities, whether we are talking about community health workers with protection gear, with investments, with putting them on the payroll. I think we need some courageous leaders, members of parliament, who will move to parliament and move bills of how we need countries to pay and to include community health workers in the salary, in the payroll. It will take the law. I think there are so many roadside declarations, but I think we need to put it in law. We do not have that in many of our countries, and we need members of parliament who can move that. I think in terms of communities who are most likely to be missed by health systems, countries need to identify and figure out where are those people, where are those communities, which communities are those, because we will not get to equity without those. And even with the strongest primary health care, if we do not know where to reach, if we do not bring community health workers who know every corner of the community, then we will still continue to leave people behind. And I think the last thing is, I think we also need to ensure that we are thinking about how do we sustain the momentum? How do we sustain the movement? How do we ensure that there is voice that is strong, that is empowered, voice that can actually point in real time when we have stockouts, point in real time when things are not going well? I think that's a voice that we need to invest in, and that voice is found at the community level mostly. And therefore, communities and civil society do play a key role in ensuring that we have stronger primary health care. And I think those are areas to prioritize in terms of investments, in terms of consideration to mainstream them even within the national policies and strategy documents. That's my quick reflection. Vineta, back to you.
Thank you. Thank you. Joanne, can we go to you, please?
Yeah, maybe just quickly, because if, when we talk about like what impact can pandemic preparedness and response have on primary health care, and the fifth is kind of right up front because it is actually being decided in the next weeks. So my first thought is like, well, partly it's kind of up to us. So like it or not, like we're the team to actually push this, and we can influence this over the next period. And sort of not give up on that, directly with the bank through our governments. And part of it is like, what are the priorities, right? I mean, if we define pandemic prevention, preparedness, response as primary health care that reaches everybody, then that is a start. And we know it's not the only thing, right? You do need surveillance, you need other things, but there is this real pull toward the bright, shiny, like exciting new thing, and not the thing that will actually keep people healthy now in the future, and detect these things as far out into the community or into rural areas or wherever that you get. So I think it's how do we take on the definition of what we really mean by this, and then really how are we just honest and smart about what entities we run this through, right? So how do we, I raised the Global Fund because it has a proven track record. It is delivering now against these existing pandemics, and it is, again, not perfect, but it is really supporting community-led response. It is supporting human rights responses. It is supporting, key populations. And so it's sort of, what are the priorities? Like, who does it run through to actually succeed? And then I also think we have to be careful that because a new entity was created, that it doesn't create like a false momentum. Like, we have to see if this thing works or not. We have to do everything we can to make it work, but we can't sort of be running new resources into this without any proven track record of like equity, impact, community-led responses. So like, yes, we need more money for pandemic preparedness. Yes, we need more money for PHC. That doesn't necessarily mean we need more money for a fifth until and unless it proves that. And again, I feel like it comes back to lots of people are working on this. We appreciate you being on the at the table and on the front line, but we really need to push this. And I think we could we have a chance to shift this and influence like where the resources go to have at least potentially the biggest impact on the existing pandemics and on primary health care that we could.
Isha?
Yeah, the only thing I have to add is that the only thing to add to that. There we go. The only thing is that we shouldn't be confused about who will make this happen. It is right. Like it's not as if the small bright lights in the struggle for health justice came from any place other than community brilliance and leadership. So unfortunately, or the reality is we all have to do it again. In some way we're sort of at this point with the bank sort of asserting that it can host this new entity, with the new entity sort of asserting that it can thread the needle with all of these questions and concerns and get it right. Well, all roads lead to trying to force that the institution, this new nascent almost fifth, does get it right because the stakes are so high. And whether it fails or succeeds, steps in that direction are the same, frankly, because we have to stress test this system and see if the most powerful around the table are willing to walk the talk. And if they're not, then we know and we move on. And if they are, then we're pleasantly surprised. But in any case, these watchwords about inclusivity, accountability, metrics of success that are firmly grounded in primary healthcare, not in some shiny new thing about pandemic preparedness that's based on what Western countries want, which is frankly a very securitized definition that is focused on higher walls, more travel restrictions, rather than the human security that those health workers in Kitebi and Chirudu and Mubende need, and all over, and in the US, by the way, right? The response to COVID and the non-response must be tremendously humbling to any duty bearer in the US that was under the mistaken impression that the health system here had any commitment to equity, whether by racial equity, gender-based equity, equity to queer LGBT populations. It does not. So accountability has to start everywhere. So we try, and we'd have a window right now that we have to act in. And I think look to the leaders in this room that includes all of you about what those actions might consist of. But we do have to hold the duty bearers who have funded this entity accountable. And I think we have some of the tools at our disposal to try to do that. And of course, we have to hope for the best. But just like pandemic preparedness is also, assuming that there will be rough patches along the road, we have to maintain this kind of pragmatic cynicism in order to have guardrails up so that the vigilance translates into this, initial down payment of 1.4 going almost 100% to country capacity. That for me is the measure. Will there be, as Rosemary pointed out, not business as usual, but instead a commitment to calling out the kind of hoarding, the kind of pushing poor country residents to the back of the queue that characterized COVID? As soon as that happens again, there has to be a different type of response, or else the fifth is culpable and it needs to be shut down, because then it's part of the problem and it's simply, gaslighting in the pandemic response rather than forging the new path that is so urgently and desperately needed.
Thank you, Asia. We have so many questions for you. Still, that this dialogue is going on and will go on, but let's see if we have some questions from audience. And if we get some time, then we'll come back to the questions that we thought we'll ask you. And then in the end, we'll just take one big thing that you want to leave the audience with and go around the panel. So any questions that audience might have, please go ahead. Yeah. There is one there.
Thank you so much. Thank you so much to the panelists and for really invigorating and difficult conversation to have. My name is Adibi Additional. I work at PAI. I've had the pleasure of meeting some of you, and I wanted to, I had two quick key questions. One around the technical committee that will be deciding on how RFPs are reviewed. I think it's important to establish the criteria for what that constitutes. Because then it comes down again to who gets to decide who's a technical expert. And then the second part of my question starts, I think from this conversation, we're already building consensus around the importance of that to get to pandemic prevention, preparedness, and response. We need to provide care now. And our goal is to provide care now involves a strengthened, resilient, as many buzzwords as possible, health system. And to that extent, it means we need to do things to ensure that more people are getting care now, whether it's through a broadened scope of what primary healthcare is, but and to tie to the other conversations that it builds trust into the health system. Now, the question is, the fifth has already we already have indicator for what the fifth can do to make a difference. Labs are important, surveillance systems are important, but they already exist. PEPFAR saw that it exists, and before that, malaria, before that, TB. We already know all those things exist. What we need now is a strengthened primary healthcare system. We have the consensus. So I think the question is, how do we build on this consensus? What are the next steps on this emerging consensus? Thank you.
You preempted our question. Anybody wants to get started?
I mean, I can answer that question about the technical advisory panel. So at the last board meeting, we actually approved terms of reference for the criteria for those members. There is expected to be an open call for nominations. It should be widely advertised. Of course, we as the civil society constituency are going to spread it far and wide, and we've already been collecting names. So if you have someone, feel free to email me. I'll put them on the list. And then those members will be chosen by the governing board. So there, and it's 20 people with a chair from WHO, and then the vice chair will hopefully be an implementing agency with experience in implementing pandemic preparedness, not an implementing entity. That's different, right? Those are the fiscal agents that the money will flow through into the countries. But so I think we've been talking a lot about that implementing agency vice chair position in the civil society constituency of who can we put forward that's a CSO or an INGO that really can represent communities, and then really push the board to vote for that. Just on your second point, I mean, I was struck in Joanne's comments, and it ties to your question about primary healthcare, that Joanne said, what can the fifth and PPR do for PHC? Which is honestly, it's a backwards proposition,
Yep.
right?
Yep.
So we're starting with this backwards proposition that we need to take pandemic preparedness money and help PHC, but honestly, we should be investing in PHC to benefit pandemic preparedness, pandemic response, essential health services, overall health outcomes. And so, we're already starting from a design quagmire. And let's hope that it gets better from here. So I'll let others speak to the second question.
Rosemary, would you like to respond?
I think and Elisha has, I think, given us the status in terms of where we are at with the process and some of the things we can expect and entry points for pushing. I think we will have to continue to call for what we believe should happen. And I think a lot of that focus is going to be shifting to the country level. So at the global level, we definitely need to make sure we have that consensus. But the proposal and the design and everything is going to happen at the country level. Like, countries are going to decide what they want to pay for using this investment. And so even as we get the consensus at the global level, we will need to think as a global community of advocates. How do we ensure that this same voice, we are connecting with colleagues, with counterparts, advocates at the country level, where we can have conversations in anticipation of this proposal, in anticipation of the decision-making process at the country level of how these priorities are going to look like at the country level. So we could have consensus at the global level, but the actual and the real change and the decision making is going to happen at the country level. And we need to take that voice there together with our counterparts at the country level. So just wanted to highlight that. And I'm sorry, I'm going to drop off. It's been a pleasure just listening and hearing all the amazing input, learning, and I look forward to continuing to work with you all in this fight. I thank you very much.
Thank you, Rosemary. One, for staying so late and participating, and second, for all that you do. And it's a lot. So thank you, thank you, thank you.
Thank you.
Would you like to add something, Joanne?
Yeah, well, first, I just thought you said it really powerfully. So, and my only thought in terms of the, also the technical review is like, how do we ensure that there are people there that really are put forward who really understand not even just health systems, but community systems and community-led responses, and, reaching marginalized groups and key populations and all of that, which seems really critical, to make this work. And, again, you said it really well. I totally agree. We have to flip it on its head, which is not how does PPR help PHC, but why, as you said, primary healthcare has to be really centered. And part of it, I would also say, is just like, I don't believe that tracking and elevating that is magic. It has to be done right. But the degree to which we're not even tracking, and not giving people at a global level or even particularly at country level the ability to track like really what share of resources in national public health budgets are going to primary health care, and where they're reaching. So some of that may be there, but it's not mostly available. So I don't think tracking is magic, but I do think accountability really matters. And so to some degree, for us to be working together to elevate that, because that is the system that we need, and that's where the resources need to flow for equity and real impact. And so I think more of that, whether it's with international institutions and or national budgets, we have to really be pushing for that.
Thank you. Thank you, Joanne.
I don't have much to add. Just the point is nominate people you think are leading lights in this area, because there is an opportunity to put forward, including yourself, to put forward qualified experts who do think firmly in this box that we're describing. Otherwise, we'll end up with, I fear, even with the best of intentions, a set of experts that do look at pandemic preparedness, prevention, and response from a much more, lowercase c conservative perspective. It's just about implementing the IHRs. It's just, sort of this very kind of, what Paul Farmer would think of as like a mode of austerity rather than abundance. And if we get people in the room, I think it will help us, who do see the firm connection between this robust primary healthcare agenda and the pandemics of today agenda as linked up with PPPR, then we'll end up with a different outcome, I hope, but it certainly won't hurt. And that's one way you start to kind of push up against the parameters of the fifth, is you get people in the room who are supportive of systems disruption in a positive and constructive way, and who do have this much more modern approach to tackling these fundamental challenges than some of the more retrograde approaches that haven't delivered impact.
Thank you, Aisha. And we'll take one more question. Please go ahead.
Yeah, thanks. I'm a health systems and global health governance researcher, so whatever I'll say in that context. What I've observed is the pandemic response and preparedness is either talking at the very supranational or the global level and max to the national level, and then on the other end at a very community, people's groups levels. What about the levels in between? Where do you think is the fifth's vision for subnational levels, or in a context like India, the block levels or the thereof? There's the whole bunch of levels in between national to people's groups. What do you think is the vision for fifth, and where do you think it should be targeting that it's not? And my second question is, there's a lot of noise continuously about primary healthcare. What's the vision of fifth in terms of primary healthcare? Is it again treating it as a pure service delivery level of primary healthcare services, or is it taking a more broader primary healthcare approach, having more people-centered ideas and accountability and community ownership? And if not, then how do you suggest should we be moving in that direction with this opportunity?
We could have the whole panel on your question. So thank you. Thank you. Anybody wants to reflect on that?
I mean, I can again take sort of the process fifth questions. So we're not there in the discussion. I mean, there's been a lot of debate in the first two governing board meetings about geographic scope. One, even just sort of thinking in the funding that will be launched, is it going to be regionally based? So there can be that consideration, because I think we are going to this country-owned piece, but is there a way to have a call for proposals that looks at countries in certain regions that share borders? I mean, that's been a big part of the viruses don't care about borders. So to only fund in the country for some of it doesn't make sense. The subnational piece hasn't come up. And I think it's worth going back to something that Rosemary said, that right now we're very focused on the governing board and the decisions being made. When the call for proposals is launched in December or January or whenever it happens, there's going to be probably a 4-month window for countries to return, right? And to develop the proposal and develop the ask, which for any of you who have worked on other FIFs, whether it's Global Fund, GFF, Jeff, whatever, how important having coordinated country input is, and making sure that communities get at the table, which for many of the other FIFs took a lot of years of advocacy to open that up and make sure that those were meaningful, that those considerations were included in proposals. I'm hoping that we can move forward with lessons learned here from that. There's been some discussion at the board meetings about leveraging existing civil society platforms to engage with governments and these implementing entities. Whether that happens, again, it's too early to say.
Thank you. If any other panelists would like to add to that, or
I mean, yeah, maybe just to say that I think your point about subnational is really important, and it kind of leads from a national priority to me rather than starting with a global priority, because I think that's when you're like looking at global priorities, I feel like there's a real danger that you're looking at what are the needs and priorities of high income countries to like keep themselves safe rather than what do countries need to build their systems. And so, but I think very much to your point, subnational is a key part, and we know the degree to which so much healthcare is devolved subnationally. So it's critical to sort of have that as like built in almost as how you think about it nationally. And I'm going to go back to your other question to how Alicia flipped it. It's like, how do we figure out, how do we make primary healthcare the sort of centerpiece of this, and understand how doing that right and well in a way that you described actually then delivers a very big key part of what we're going to need for pandemic prevention, preparedness, and response, and drive from that side. Is the fifth there? No, but I also think we have a chance to kind of shape that, and then the larger kind of debate in this moment, we can use this to shape the fifth directly, but also use it to shape the bigger dialogue, building off of that. And I feel like we have to.
Can I just add one more thing to
yeah,
that?
yeah, please.
So I think your question about how is PHC being thought of is a really excellent point. And I think I'm sad to say that it's the service delivery, right? That's what's being considered. And so it's just a reminder that whatever funding flows into the country, hopefully the country's proposals are well designed and include subnational and really a lot of community outreach and marginalized populations. That money can only operate within the policy system that exists in the country. So if there are barriers at the national and subnational level to services because there are bad policies on the books, there's not enough training, there's not, health worker, again, protections and education and everything that goes into that. My understanding at this point is the fifth is not going to work on policy change at the national level to advance primary healthcare. It's going to be service delivery focused in existing in whatever system currently exists. So for people who are advocating to advance primary healthcare policy change, it's going to be another layer to add into the mix. I mean, we face the same thing with the universal health coverage approaches, right? Universal health coverage is not a panacea. This money is not a panacea. It's going to operate within the system that exists.
Thank you. Thank you so much. I think we want to keep a few minutes in the end for people to just mingle and have follow-up conversations, and we'll end at 4:30. So last round, any one thought that you want to leave the people with? We'll start with you, Asia.
I mean, just to appreciate the leadership from people in this room who recognize that getting the right answers to these questions requires the commitment to interconnectedness and to understanding how our current health architecture has fallen short of the imperative to deliver these essential countermeasures and caring responses. And to have watched and experienced the nightmare of COVID over the last 2+ years, play out in our communities and all their diversity is bad enough. And then to see the fifth, potentially take up some of the corrective language, but then not deliver feels like an additional potential betrayal. So the stakes feel really high because they are.
Mm-hmm.
So I just look forward to going forward and trying to get the best out of terribly bad situations, because I know that we can try to raise additional, non cannibalizing resources. We can try to embed and imbue in global health architecture these, more than tokenistic sort of nods toward inclusivity. We can ensure that frontline interventions for PPPR actually look more like frontline interventions for primary health care and prioritize the people who'd make the systems work. We can do these things and we have to.
Thank you. Go ahead.
Yeah, I also just appreciate being together with folks. And I'm going to come back to what I said before, which I just think we have this moment to, in part to shape this particular mechanism, or to at least to work to shape that. But I think within that, because there's a lot of, including political attention on this, we actually have an opportunity to help shape what we mean by pandemic prevention, preparedness, and response. And I think we can use it like we don't have to measure it only by what we do or don't achieve on the 5th, though we have to do our best, because that, $1.5 billion is a lot of money in this moment, especially applied against the sort of existing needs and, what it can jumpstart. But I also think we can use this political moment, where there's G20 attention and when there's attention of a whole group of the world, to actually drive for a definition of this that really is centered around what people have been describing as also a holistic, primary health and public health system response. And so I think that's what we have to do. And so it is up to us. And I'm really looking forward to working on it with some people I've worked with a long time and some I've just met in the last few days, but really excited to work together.
Thank you, Joanne.
Just plus to everything Joanne and Asia said. I think I'm going to just focus on the civil society piece, right? And just, it was an uphill battle to get these voting seats on this governing board, and not welcomed by some at the World Bank, not welcomed by every country that's in the room. And so it feels a little bit as if they are all regarding it as a test case, right? Can civil society come as constructive players? Are they going to burn it down? But I think that we too need to put them on notice a little bit, that it's a test case for us. We're trying to play in your system right now through this, but if it doesn't work out, we're going to change our strategy. So I just want us to not feel like we're the beggars or the poor cousins at the Thanksgiving table. We have value. And if they don't recognize it, this strategy doesn't work. So we also need to really take those lessons learned as a civil society constituency and think about how we proceed in interacting with the duty bearers.
Thank you so much. It has been such a great discussion. And for last 3 days, we have been organizing different angles of this discussion. I think I'm ready for PhD on 5th. And then also, please don't forget to pick some action swag. And as I mentioned before, Action is a 15-member partnership based in 5 continents. And if you can see Sabina sitting there with the camera cover, it's really cool. And then the second is the stand. And now can we give our swag to the panelists, please? Would somebody bring it to us? Pack the little swag bag thing. Oh, nice. Oh, it's Thank you. Hold on, hold on. Yes, please do. Oh, that's awesome. Yes, health equity. That's our hashtag too. Thank you. Thank you so much. Thank you.